Good morning, good afternoon, good evening, depending on where you are. Welcome to the second session of the AFM Symposium. Just setting up my screen still, so hang on a second here. Okay, there we go. I'm going to talk about critical care management of AFM. I have no disclosures. I have 4 objectives to my talk. I'm going to describe the frequency with which AFM patients are admitted to the ICU. I'm going to define which AFM patients would benefit from ICU admission. I'm going to delineate the symptomatology of AFM and how to monitor for deterioration. I'm going to establish the importance of supportive care. So, current literature tells us that 50%, more than 50% of patients with AFM are admitted to the ICU at some point in their disease process. You can see from the studies below that the high rate of ICU admissions are seen across different locations, but the mortality is very low. In fact, when we exclude patients that are adults and those with mortality after discharge, the mortality rate is even lower. So why are patients admitted to the ICU? They're admitted to the ICU almost exclusively for the monitoring and support of respiratory compromise. And what are the goals of ICU care? Well, first, we want to limit complications through rigorous monitoring and supportive care. Then we want to facilitate a rapid and accurate diagnosis. And finally, we want to provide disease-specific treatment. And for AFM patients, we know at this point it's largely supportive care, but we do hope in the future to be able to provide more specific treatment for AFM specifically. And what are the criteria for admitting a patient to the ICU? Well, this varies quite a bit across institutions. There are some institutions that have a conservative model where when a patient is suspected to have AFM, they would admit them to the ICU for the first 24 hours of monitoring due to the concern for rapid deterioration. Other centers have slightly more rigorous criteria, such as admitting only high-risk AFM patients, and those would be patients with bilateral upper extremity weakness, bulbar dysfunction, or MRI with a cervical cord lesion. Finally, in many centers, the criteria for admission would be that are standard for all patients, where if a patient demonstrates that they need support for respiratory insufficiency or failure, they would go to the ICU. What are the symptoms of AFM? Well, we know patients are admitted with limb weakness, and we also know that many of them can go on to have respiratory distress. But we also know that patients can have feeding dysfunction, pain, paresthesias, neurogenic bowel bladder, or autonomic dysfunction. I've attached a table here on the side. It's quite busy from the cane paper that brings together visually a description of some of the secondary symptoms based on the number of limbs affected by AFM. You can see that the more limbs involved, the more likely you are to have some of these other symptoms. The good news is that even in severe cases, patients do make a full recovery. So the number of limbs involved does not appear at this point to predict whether you'll make a recovery or not, which is all the more reason to provide good supportive care for the patients that need ICU care. What is the rate of progression of symptoms? How long should you monitor someone, and how do you know when the symptoms have reached their nadir? Well, there's a paper published by Gordon Lipkin. It was a small paper of 16 patients, but they showed that more than half patients deteriorated within a period of 6 hours, so a hyperacute pattern. They had an onset of symptoms, and then they were at their worst within a very short period of time. One patient's time frame could not be determined, but the rest all actually progressed to their nadir in less than 72 hours. So it seems with some confidence we can say that patients are generally deteriorating over the course of the first 3 days. And in AFM, there's sort of a single phase. So you're admitted, and then you get worse over a period of days. It does not seem that there's ongoing progression or a stuttering course. What are risk factors for respiratory failure? We don't really have a lot of literature to guide us at this point, so we can divide up our risk factors based on the type of respiratory failure a patient may have. We know that when they're weak, they can develop hypoventilation. So looking at patients who have weakness of the trunk or the bilateral upper extremities would be a patient we would be concerned about. A patient that has a cervical cord lesion could be a patient that we would be worried about. The cervical cord lesions by themselves do not predict the need for respiratory support. Patients can have aspiration leading to respiratory failure. Those are patients that have bulbar weakness are most at risk for aspiration, or those that cannot maintain a period of wakefulness. Apnea is slightly less common, but also still present. So patients with brainstem lesions, bulbar weakness, or weakness of the neck and trunk should also be considered at risk for apnea. I added this slide as a reminder of how complicated the mechanisms behind respiration are. We know that AFM frequently affects the cervical cord and brainstem. As clinicians, we learn the phrase C345 keeps the diaphragm alive, but breathing is so much more than that. Yet the phrenic nerve controls the diaphragm, but the brainstem also has a central role in the rate of respiration and the muscles of the oropharynx. Even the thoracic cord controls the accessory muscles involved in inhalation and exhalation. What is the incidence of respiratory failure in AFM patients? While respiratory support is the most common reason for ICU admission, it's really unclear how many of those patients need actual mechanical ventilation. So looking at the studies listed above, you can see the range is 8 to 66%. But if we exclude the European study, which was retrospective and by survey, and may have had a selection bias, it seems that the rate is somewhere between 8 and 25%. There are other symptoms associated with AFM that are not really consistently reported in the literature. I sampled the experience here at Children's National for a period of 5 years. We had 20 AFM patients, and these are the rates for constipation, neurogenic bowel and bladder, and neurogenic bladder, dysautonomia, and pain. You can see that constipation occurred quite frequently. Neurogenic bladder occurred in about a third of patients. We did not see any dysautonomia in our patients, though I know other centers have reported, specifically in the ICU, that they've seen autonomic dysfunction. And then probably what gets less attention is pain. Lots and lots of patients have pain, and and sometimes it can be difficult to identify pain in AFM patients. So in the ICU, we have lots of monitoring and support, and this is ongoing, consistent, and there's a lot of interplay between the two. I want to take a moment to acknowledge respiratory failure from neurologic causes. So we know when children have intrinsic lung disease, such as asthma or bronchiolitis, we can often see the distress that they have. They look distressed, they're coughing, they're wheezing, they clearly have tachypnea, you can see it on the CR monitor. The distress is visible and audible. When children have respiratory distress from neurologic causes, it can be much more subtle. The patient may not look distressed, often because they can't move. The weakness does not allow them to express the stress that they may be feeling. They may also be sleepy or lethargic. They may have clear lung sounds, and the CR monitor may not do a very good job at picking up the chest wall movements. Even the oxygen saturation is often normal until the compromise is quite severe. So how do we monitor a patient that is not clearly distressed? We can look for the things that we've discussed before: hypoventilation, apnea, and hypoventilation. We usually put patients on an assessment schedule. So often we'll say every 4 hours they should be formally assessed for breathing. And in a patient that's greater than 6 years of age, we would often do pulmonary function tests. We would perform a NIF and a forced vital capacity. For children that are not cooperative or younger, we would do a task at the bedside, such as asking them to count on a single breath or singing a song. That way we could assess whether they can, their lung capacity at that point, as well as consistency over time. Of course, pulse oximetry is important, though I want to point out that hypoxia is really a late sign of distress in a patient with a neurologic cause of respiratory distress, though it may also be evidence that there's a secondary process, such as an aspiration going on. For apnea, we want to have patients on a CR monitor, but of course, again, we want to be cautious that when patients are weak, the chest rise may be subtle and hard to pick up on the monitor. We also know that patients that have AFM also have a high rate of asthma, so we want to make sure that we're assessing for concurrent conditions. Becky Riggs is going to talk next about respiratory care, and I don't want to get too much into that except for to say that there are lots of ways that we support patients, not just with intubation. Sometimes we can give non-invasive ways of ventilating someone, and we, of course, want to perform routine pulmonary toileting tasks such as chest PT, cough assist, and early mobilization. In terms of aspiration, we want to identify the patients that are at high risk for aspiration. So patients with bulbar weakness really should have a close assessment for aspiration. Those would be patients that have a hypophonic voice, drooling, copious secretions, dysarthria, fatigue with talking, patients who are not maintaining a level of alertness. We should make those patients NPO and obtain a swallowing of valve as quickly as possible. And once an aspiration event is identified, we want to act quickly. So patients that develop fever, hypoxia, or new onset tachypnea should be assessed for aspiration. We want to make sure we modify their diets quickly. We don't want to continue to feed somebody that may be aspirating. And of course, we want to assess for infection and increase their respiratory support as needed. Other ways that we can monitor patients with AFM outside of the domain of respiratory function is to do neurologic assessments to see if they're still progressing in terms of their disease process. We would perform neural checks normally, and in the interval with which you would assess someone can vary. I want to point out that if we do neuro checks in an interval that is shorter than Q4 hours, we need to be careful for patients that are in the ICU for more than a day, because when sleep deprivation sets in, patients often can become delirious, which makes it difficult to assess them. Also, in terms of assessing a patient for neurologic function, it's often very helpful to ask the family to video the motor exam, speech, or facial movements so we can refer back to them later. Of course, we want to monitor hemodynamics and put a patient on the CR monitor. Hypertension is very common, but the etiology is likely multifactorial. When a patient is hypertensive, we want to make sure we assess for pain, neurogenic bladder, and autonomic dysfunction. Pain management. I think pain often does not get a lot of attention, but really can make the difference in our AFM patients. So children that have neuropathic pain often don't say they have pain. You really have to be quite creative in how you ask them or how you assess them. So any child that is irritable or poorly cooperative may have poorly controlled pain. We know that when patients have good pain control, it can normalize their vital signs and improve cooperation with assessments and therapies. We want to encourage the use of non-narcotic medications. For example, gabapentin can be quite useful while allowing you to continue to assess your patient that it does not have altered mental status. We want to take care of the social emotional health of our patients. We want to consult psychology and child life early because they can really be helpful in managing the anxiety and behavioral challenges. And then, of course, for patients that are in the ICU for more than a day, we really want to promote sleep and the consistency of day-night cycles. Also, I'm not going to speak too much about sedation here, but I do want to acknowledge that we want to minimize the sedation when possible, as well as other medications that may exacerbate weakness. I know Dr. Riggs is going to talk about this a little bit more in her talk next. Bowel bladder dysfunction is also fairly common. So I reported earlier that bowel bladder dysfunction is reported to occur in about a third of patients. I actually think that the gut dysmotility is probably much more common than that. We want to really do a good assessment for constipation and initiate a bowel regimen much early. For the neurogenic bladder, it's sometimes quite difficult to assess this in a child, and often if you don't ask, you don't know. So for children that are continent using the toilet, we would often ask them to perform, ask them to urinate and then perform a post-void bladder scan, or if that is not available, a post-void residual. And then for patients who are identified to have a neurogenic bladder, we would prefer that they be managed with an in and out cath schedule as opposed to an indwelling Foley catheter to minimize the risk for infection. Nutrition is, of course, important. And for patients that are being assessed for aspiration risk, we often want to make sure we don't have gaps in feeding. We want to make sure we modify their diet and not just make them MPO. So if they're safe to eat, for example, pureed food, then we would want to make sure that we provide that and encourage them to eat when possible. That being said, when patients are not safe to eat, we want to really make sure that we provide them nutrition enterally as soon as possible, and that often requires the placement of an NG tube. Mobility and rehabilitation in the ICU is a very hot topic right now, and in AFM patients, I would say it's probably as important as it can be. So we want to make sure that we consult PT and OT as well as PM&R early for an assessment. We want to plan for mobilization, and the first step for planning for mobilization is to establish when is it safe to move the patient. And then once we establish those parameters, we want to make sure we set activity goals and get them moving as soon as possible. Of course, for patients that are in the bed and unable to be mobilized, we want to make sure we provide good skin care and avoid pressure palsies. We want to provide DVT prophylaxis for the patients that are post-pubertal. And we want to do stringent assessments for infection and treat quickly. I'm going to talk briefly about diagnosis. So while we're trying to support and manage all these different things, we want to make sure we're also trying to get to the root of the cause of the patient's weakness. So we hope to have soon standardized criteria for AFM diagnosis, and we want to encourage that we identify those patients consistently. It's important that a diagnosis is made because the differential for weakness is quite varied. I'll use the example that patients can come in that have weakness and they may have AFM or they may have a stroke. And the way that a stroke is managed is, of course, quite different than you would manage AFM. So an early diagnosis really can dictate what's going to happen in the first few days for that patient. Of course, we want to do a good physical exam, which may be helpful, but many of the ways that we diagnose AFM include procedures that require sedation. And Dr. Riggs is going to talk about this a little bit more, but we want to balance the need for information to make the diagnosis with the risk of progressing symptoms. I'm going to talk very briefly about outcomes, mostly to say that really the data is incomplete at this point, but I do want to acknowledge that there are patients that have ongoing needs for support. I sampled this paper here from Kane. Of course, it's a small number of AFM patients, only 27 patients had follow-up available at 12 months. But you can see that 11% still required a tracheostomy and 15% required a G-tube. Probably those patients have overlap, so many children that require tracheostomy are also the patients that require a G-tube. But we want to be able to identify those patients early so we can make an impact and avoid this dependence wherever possible. So in conclusion, we know that more than 50% of patients are admitted to the ICU during the acute phase. We know that about a fifth of patients require invasive respiratory support. Most are monitored and supported briefly before transitioning to a floor status. That's some pretty good news. It's not the majority of patients that are staying in the ICU for long stays. ICU admission can be considered for patients with weakness of the bilateral upper extremities, neck, trunk, or bulbar dysfunction. Respiratory failure occurs predominantly in patients with brainstem or cervical involvement. The neuro exam is your best guide. The imaging abnormalities may contribute to identifying high-risk patients, but it is worth knowing that if studies are obtained early in the course, they may be negative and therefore not helpful in guiding acknowledging when patients have cervical involvement. Any child that has an early MRI that is negative but symptoms of cervical involvement should have a repeat study within 2 to 5 days. We know that good support can impact the primary disease. So patients that have good support can be mobilized earlier, they suffer fewer ICU complications, and they spend less time in the ICU overall. And with that, I'm going to transition to Becky Riggs.